So just an acknowledgement, I'm pretty proud to be working, living and playing on the unceded ancestral territories of the Musqueam, Squamish and Tsleil-Waututh peoples. We also operate and function on the territories of the Comox people. And the Comox people on Vancouver Island have been a massive support to our project that we're going to talk about right here. So we're very grateful to them. So I'm hopefully going to talk to you a little bit about where we are and where we aim to be. And I've been talking to a number of people here today. And by the way, isn't it amazing to be here in person after so long? I've had so many rich conversations in the last 2 days that it just reminds me of how valuable these forums are, not just for the blah, blah that maybe I'm going to give you, but for the relationships we sustain, the exchanges that we have. And I was just trying to look at my calendar. This time last year on this day, in 2020, I was in an EOC talking about PPE. And I bet many of you were too. But here we are talking about the future, which is much more interesting. I got into this business as an occupational therapist, an angry occupational therapist, I would have to say, working in long-term care, wondering what the heck those management people were doing about what we were trying to achieve, a day well lived for the people that we cared for. And I'd like to think I'm not as angry as I was. I'm still stuck in the management gig, and maybe at some point I'll get out of it. But the point is that if you look at that picture on the right, and I chose a tasteful picture, I could have chosen other pictures, but for many of us working in long-term care, I think we'd agree we have good care. In many places, we have great care. But is it excellent care? And is it where we really want to be? And is it what we really would like to have for the people we love and care for? I'm not sure I could answer that as a yes, but I think people in this room would probably agree that we aspire to that at the very least. So that's what we're trying to do at Providence Living and Providence Healthcare. So we hope that we'll have something approximating the chap over my right shoulder in the coming years. So I'm going to talk to you about one of our projects, and at the end I'm going to give you a sneak preview into one of our other projects. But we're currently rebuilding a 156-bed care facility on Vancouver Island with the support of Vancouver Island Health Authority, as well as our partners, the Comox people, BC Housing, and a couple of others. I've got a slide at the end that tells you about all of our partners. But we're rebuilding an existing 4-bed, 25, 30-year-old care facility on a 14-acre piece of land on Vancouver Island in Comox. We're following, we think, or we hope, we're following the best practices in dementia care that we've experienced and have researched in the last few years. Approaches like Eden, Greenhouse. We've also studied extensively the Hugway model in Holland. We've been to visit them. And so what we're trying to do is to transition ourselves, and this is a quick promo for a session from my colleague Jennifer this afternoon, transition ourselves from what we consider a task-driven medical model. Nothing wrong with the medical model. We need physicians. We need a medical approach to long-term care. But the way in which we deliver that care is really very task-driven and very much about us, about our schedules as staff, about what we need to get through a day. It's not about the way the resident would choose to live their day. So the phrase that Hugway uses is moving from task-driven to social relational. And if you really want to understand what social relational is, I commend you to come here at 2:30 this afternoon, where my colleague Jennifer will give you a much more in-depth look at what we consider social relational. Our goal is to bring together all of that theory and try and truly live it out in an environment, both physically and with our residents day to day. And I've talked to a few of you today about the fact that very few of us in this room will argue with the principles that we're going to be talking about here. None of it's really new. We have not invented a new widget. We are determined, though, to do what all of us have thought about, at least me, for the last 30 years, the things I've been angry about. We're determined to actually make it happen in the face of bureaucracy, funding challenges, COVID, human resource challenges. We are determined to make it happen, and I hope we get that across here. We're really lucky. We have a 14-acre site of a retired acute care hospital. And once we've built the long-term care facility that we're currently building, the 156 new facility. We'll be building out the rest of that site to be a seniors village. We called it a dementia village to start with, but only 60% of our clients have dementia. So although it will be very much geared to people with dementia, we hope to build a village that any senior with frailty would enjoy living and welcome in their family and loved ones too. Oh, look, I put the partners on this slide. So you can read, there are our partners, not to mention the two healthcare foundations that are funding us for close to $7 million of donated money. Very important to keep them in the frame. So just an overview of the building that we are building. So we're building to the current design standards here in British Columbia. So private resident rooms, shower, toilet, and basin. They're all around 260 square feet with their own washroom. The washroom is a wet washroom, so you can shower at the same time as, not at the same time as using the toilet, but you can use everything independently. You have to have a few glasses of wine, I guess, to do that. So we do have a spa, so a tub room for every 12-room household. I should back up. So this 156 beds is divided into 13 distinct 12-room households. So and I'll show you some pictures in a minute, but the 12-room households are separate and distinct, and they're intended to be standalone. And each of them can function independently. We do, however, one of the things that we didn't quite have the courage to do was to do away with a commercial laundry and a commercial kitchen. So we do have a large commercial kitchen, large commercial laundry, although our intent is to use the communal kitchen and laundry in the 12-bed suite. So every 12-bed household has its own kitchen, very residential designed to fight the public health inspectors on the design. So it's freely accessible to residents. It's not, the initial design was actually a little prison. If you could get into it, you might be able to use the stove and the kitchen, but you would have a hard time getting in if you were in a wheelchair or if you didn't know how to work intricate locks. So we've removed all of that. It's a very open space kitchen. Same with the laundry. So our hope is that at least 2 meals a day, breakfast and lunch, will be prepared with residents, either independently themselves or with assistance in the household. But we do, as I say, we didn't quite have the courage to do away with a big commercial kitchen. So the main meal at the end of the day will likely be delivered from the main kitchen. You'll see in a minute a picture of our bistro. So we've embedded a bistro into the design. It has we have one of the best views probably on the north end of Vancouver Island. We look to the southeast toward Vancouver with mountain views and ocean views. It's pretty spectacular. But the bistro will have the best view of that water and mountain view. And it'll be a licensed bistro. So yes, we will have a liquor license. The goal is that it will allow residents, whether it's for breakfast, lunch or dinner, to access a casual dining with family. So you may choose to have breakfast in your household, but you may choose to walk across to the bistro and have a coffee and muffin at 11 in the morning when your daughter comes to visit you. So that's kind of the goal. It's not a restricted bistro, and we're working with one of our volunteer foundations to hopefully run that. We have a nice community hall, smaller than this, but a bit like this, where all sorts of events can happen. The wellness center is kind of the exercise area. There'll be a physio gym, great presentation this morning on the importance of exercise. So we'll have that. But the goal is that people will leave their households, come to the wellness area just as they would in the community. They go and make an appointment and come across. We do have ADP, adult day program. So that is one of our existing contracts with the health authority. We retain that. So the adult day program will be retained inside the building. We are a Catholic healthcare organization. And so we have a central chapel. You'll see a picture of it shortly. That'll be inside a central courtyard. That's a key aspect of our care program. But really, for the first time, I think, in a facility of this size, we've partnered with the Comox Nation, and we have an indigenous big house, actually quite small. It's about 350 square feet, but it is designed by the Comox people. And it'll be used exclusively by Indigenous residents that we have in the building. So you're going to see very shortly, we have enclosed courtyards and balconies. You'll see that very shortly. So this is a picture from above. And this is pretty much, the interior courtyard is going to look different other than I don't know if I've got a pointer here, but as you look at it on the top right, the little pointy building in the middle, that's our chapel. And on the bottom left, the little red long rectangular building, that's the Comox big house. Barbecue adjacent to the bistro. You can probably detect the bistro with the two umbrellas. So that's the sort of publicly accessible to all residents bistro. And the blue section on the bottom left, as you look at it, that's the top level are resident rooms, but the second two floors below it are where all the back of house things are. The bistro, the wellness center, physician, dentist office. Again, when physicians come to the site, their residents will come visit them in their office, just as they would in a community. We want to limit the number of physicians or number of people that go to visit households with no purpose related to the resident. So if the physician wants to go to the household, of course, that'll be acceptable to us. But the goal is that we function like a little small town. So everything on the bottom left-hand corner, as you look at it, is the sort of back of house function. Everything else in that circle are resident rooms. So we have 2 levels. And every 12-bed room or every 12-bed household is a replica of each other. Lynn, you'll see them in a second. This is a very early, I know you've got an order of Canada, but questions come at the end. Just kidding. Yeah, I can't argue with Lynn. She's like the godmother here. Yeah, so this rendering doesn't show the balconies, but they're all through. On the second level, trust me, they're there in the real thing. You'll see it in a minute. Thanks, Lynn. Yeah, no, you speak up. You've got an order of Canada. You can do what you like. Front entrance and the glass thing there is the bistro. So just another picture of coming into the front entrance. And on that ground level is where we'll have all the sort of amenity spaces, art room, and so on. So the terms of reference said I had to talk about design considerations. And the thing, I guess the caveat here is that this is a government funded in British Columbia a rebuild of an existing care facility. Island Health, our great partners, didn't give us a single cent more than they were giving us for the old facility. So we have to build this facility and operate it with the same money that we have for the current facility. So that gives us an awful lot of challenge in terms of, particularly in the current construction market, with the cost inflation of materials. However, we've done what we can. So my excuse in 2 years' time when somebody says, why did you do that? That's stupid. Government funding. That'll be the reason. So we did talk to Carol Estebrooks and Dr. Habib Chowdhury early on, and they had some great suggestions. Unfortunately, we couldn't incorporate many of them because we were already far down the road. So this is not a perfect design, and I don't present it as such. It's got lots that could be improved. Again, apart from government funding, we can point to regulatory guidelines and licensing regulations and the BC Building Code. Very, very institutional. Currently, the BC Building Code restricts things like, for instance, you have to have 8-foot hallways. That means you have to have smaller resident rooms. Do you need 8-foot hallways with a building to the level of sprinkling that we have at 2 levels? Our architects and we argue not, but the BC Building Code says you have to have them. So we have lovely big wide hallways, which are kind of nice for an airy feel, but it takes away space from residents. And this is about a living environment, not an overly safe environment. We had to retrofit, because of COVID, we had to retrofit a bunch of additional staff spaces to allow for each 12-bed household to be completely segregated in the event of an outbreak. So staff can come into the building, They can manage COVID, and we can shut that 12-bed area off without impacting the rest of the building. So you don't have to have visitor restrictions for the whole building if you only have an outbreak in one 12-bed area. Dehugwe are big on their grocery store, and anybody who's been to visit that site will know that the grocery store is a big part of that culture. People come down, staff and residents come into the grocery store every day to do their shopping. Now, we've installed a grocery store. We're going to follow that model. But when I went to Dehugwe and saw the grocery store, I realized, oh, it's also their storeroom for the whole facility. So that's why it's so big. So if ours was bigger, we could do more. So we're playing around with that right now, but the architects aren't too happy with us because we want to make that grocery store bigger. Bistro kitchen, we'd love to have put a full kitchen in there so that we could, do French fries. We can't do that for various reasons, mostly to do with fire suppression and cost. I've talked to you about already the fact that we have a mixed population. And certainly the clients we take, for those of you who are not from British Columbia, we don't get to choose our clients. Dehugwe is very careful, and I love Dehugwe, but they're very careful to choose clients that exactly fit their population, exactly fit their environment. We have to take the next person on the list that the health authority tells us to. So we have to have a very flexible design, and we have to have a very flexible approach to care, which is pretty tricky when you've got various levels of dementia, as any of you in the long-term care business will know. We chose not to cover our outdoor walkways. So we are, and we're getting a lot of pushback from our staff on this. Again, we're following that Dehugwe approach, but it means that from each household, you'll need to get up in the morning. If you're going to the gym or the hairdresser or to see the doctor or the art program or the bistro, you'll have to put a coat on and take an umbrella. And, we're a pretty rainy, cold part of the world in Comox. So that was a very deliberate design choice. We found that with the covered walkways, the environment just does not look as inviting. It looks very institutional. So we got, to their credit, Island Health supported us in that choice, and so we're going with it. So we may rue the day, but that's where we're going. No nurses station. Poor nurses, they will have a table that they can use, but they will have to come in with their laptops. The medications will be stored inside each 12-bed household. But the nurses, we're telling our nurses that you will be community nurses. You're visiting a community and you have to act as such. And again, Jen will give you a really good description of how that's going to work. We've done an awful lot around the HR. One of the key things to the operational change is new job descriptions. So we have gotten 3 really cool job descriptions approved by the union and HAVC, which mean we can change the way people experience care. We can eliminate a lot of that task stuff by having workers be multitask. That's not workers on the cheap doing lots of stuff on the cheap, because our model is actually costing us about $3 million a year more than the health authority funds us for. See, there's some Island Health people on the call here, more than the health authority funds us for. Just pause for effect there. And not sure how this is going to work, but in order to get that care model to where we wanted, we researched supply robots. So we do have a 24-hour robot system installed. It's not installed yet. The power is there, but the robots haven't arrived. And that's allowing us to divert about 2 FTE from support duties to care duties. That brings down that $3 million cost that I talked about. So the robots, we've really got our fingers crossed on that. We did a lot of research. Some lucky people got to go to San Francisco, but there aren't any Canadian facilities with the robot system. York General Hospital is going to be the first, we'll be the second. And so we'll see how that goes. So just a quick look at the floor plan. You saw the courtyard a second ago. We've circled on the bottom right there kind of the size of a typical household. And I've already told you on the other side is the community spaces. But each household does have its own tub room. It's got a back of house office. This doesn't show it particularly well. So if the staff do need to have a little family meeting, they can either have it in the residence room or they can go into the back office that each household has. And that's one of those blue spots. Anything blue is a non-resident spot. just conscious of time here. So this is the back of house. You see that gray sort of tunnely looking thing that's where the robot's going to function. And that goes all the way around the circumference of the building. The robots go to the elevators and they come up and they deliver stuff outside the household. So residents won't see material coming into their household. They won't have carts. The institutional stuff we do, because we need to be efficient, all of that stuff happens out of their site, which we think is a really good thing. But this is the ground floor where all of our back of house stuff is, the FMO office, the kitchen, laundry, and so on. Oh, look, I had that slide there, so you can see where everything is. Oh, I forgot. We've embedded a childcare. I forget how many spaces. Jen will tell you how many spaces that is. That's primarily for staff, but it is open to the public. Staff will have first refusal on childcare spaces, but that's again part and parcel. And the children will have access to the central courtyard garden. So mixing generations, again, that's a principle. Eden, everybody talks about that. Remember, I said there's nothing new here in terms of what we're doing. We're just actually doing it. Is my argument. This rendering of the inner courtyard garden, it's changed a fair bit, but it looks very, very much like this still. You'll see a couple of pictures in a second. But what we're trying to do here is create an environment that residents really want to come to, but more than that their families want to come to and their children want to come to, so that they will come and be with mum or dad in this pleasant environment. It's completely enclosed. So although we're right on a cliff, the wind shouldn't be too bad. We were there 2 days ago, and the windows are not yet in, and the wind that was howling through the building was just ferocious. They couldn't put plywood up because it was so bad. So we're really looking forward to the windows. So again, Jen will talk a little bit more about this afternoon. This, I think, is going to be the ultimate layout. You'll see the raised vegetable beds. On the right of that picture, as you took a look at it, that again is the Comox longhouse and the chapel in the background. Just another view of the courtyard. Lynn, I'm looking for the balconies. Do you see the balconies on the far right? They are actually shown there on the far right of that picture as you look. Oh, sorry, on left as you look at it. Yes, your left. That was a test. That was a test. Your amyloids are good. And just to prove that we're actually doing it, this is it. This was 3 weeks ago. We were there 2 days ago, and the roof is on the whole building. So everything you see there without a roof, the roof is now on. And you get a slight sense of the view. So the residents that will be on that sort of south-facing side will have a spectacular view. That's our building. Not sure what the time is, but we're very lucky that in my capacity as a VP at Providence Healthcare, we actually have one of the few new long-term care facilities under the new government program approved. It's a building called St. Vincent Heather, and it was just announced by the Minister of Health 2 weeks ago. So this is a 240-bed facility just near BC Children's Hospital if you're from Vancouver, but it's essentially what we consider an urban seniors village. We're very grateful to the Catholic Diocese who donated the land to us. And essentially what we're going to attempt here is it's actually 13 stories above ground because of the slope of the land, but it's actually 11 stories of care. So it's an L-shaped building, and you can see those outdoor balconies. Again, 12-bed households. The household design is almost exactly the same as Comox, but we've got 4 or 5 years to learn from any mistakes we've made. And we've probably made a lot in Comox, but we'll learn from those mistakes and perfect this building. But this building is now approved. We're just before Vancouver City Council right now for our zoning permit, and we'll be in construction, we hope, within 2 years. And that's really a factor of the city of Vancouver, not really us. But we have about 5 acres here. And our goal is to build the rest, all the green stuff you see. That's where we'll be building a really enclosed outdoor garden for the residents of this building. And we also have plans to build some supportive housing for aging in place on the same campus. Another view of it, you can see the balconies on this one. We have to go up in Vancouver because we can't go out. And so, you know, I've worked in care facilities that are high, and honestly, it wasn't that pleasant. So hopefully we've got a pretty good spacious, because of the new design guidelines, we've got a spacious environment. But we're really working hard right now, which is why the model of care is so important. And Jen will talk to you about the fact that we're also currently trialing our model of care. We've set up a pilot household at our site in Comox, and shortly to be setting one up here in Vancouver to test before we move into the new buildings, test all these new job descriptions, test how does it work if residents are preparing their food. And I'll be very honest, staff are happy, they sign on, but as soon as they have to change, remember that slide this morning about change, there's resistance to doing things differently. But we have great staff, we have a great leadership team under Jen, and I'm confident that we can move people to where they need to go, because I think everybody feels this is the right thing to do. Fingers crossed. Yeah, so just, I think, another view there. Now, I think, how's my time? Oh, we're almost there. So the next few slides were going to be about the model of care. I think I've promoted it enough. So I'm going to stop there. And this is where we aim to be. This picture this is actually a Dehugwe picture. So this is where we aim to be.
Thank you very much, Mark. That was great.